urinary creatinine in your urinary level. So we're going to deal with really 6 main kidney issues today. The first one we're going to deal with is the dreaded AKI kidney injury. Before we get too worried about it, we just need to understand basically what it means is we get all these clinical findings, and it seems to indicate that the kidneys are not functioning as well. There's too much nitrogenous waste product, meaning the BUN has gone up. And either they're not urinating at all, they're oliguric, or they're not oliguric, meaning they're urinating fine. They're getting 500 milliliters of urine output per 24 hours. Yeah. I used to be into like doing, some of you may even remember before Keurigs and Starbucks. You used to be able to have a coffee machine that you put a filter on. You may even been able to put a timer in water and you wake up in a pot of coffee. That's the next morning. It doesn't matter. My experience was there are 3 things, assuming something went wrong, right? There are 3 things that could have gone wrong that would make me have more work to do in the morning than the other. One would be I'd wake up in the morning and I forgot to put water in the coffee machine. And it's out there trying to make coffee all night, for an hour or so, nothing came out. There's a little bit of stuff on the bottom, super concentrated, and the coffee machine wasn't, right? That's one. Sometimes if I was really tired the night before and I set it up, the filter wasn't in quite right. And as the hot water was going into the coffee filter, it wasn't holding on the water well. And then you get some coffee grinds mixed in with your coffee because it just wasn't filtering well enough, but there's some filter. And then sometimes a little bit of ground coffee would get underneath the filter. I don't know if any of you have ever experienced underneath the filter by the outtake valve. And then like you got filtered coffee, but it started to build up, right? And then got coffee mixed in with it too, and just sort of overflowed the basket, right? So that's essentially the difference between pre-renal, renal, and post-renal. Okay, pre-renal, there's not enough fluid. You've got to put water in the coffee pot. The urine has high osmolality. The FeNA, the amount of sodium coming out is less than 1%. And often it's going to be something community. For some reason, just not enough renal perfusion. There's not enough fluid going in. With those patients, really the first thing you want to do is do fluids, right? The second one is renal. There's something wrong with the filter itself. There's holes in the filter. I think put in wrong. But there's holes in the membrane, right? So you're going to get some casts. It's going to be a higher than normal excretion of sodium, higher osmolality if it's AGN, and there may be some proteins in the urine. And then post-renal, everything's really filtering fine, but it's backing out, it's causing some damage to the line. Again, it's going to be higher, and then it's going to affect the kidneys themselves. This is some hemoglobin, some leuks, and again, a higher FeNA. Okay. So volume depletion. So if it's acute renal failure because of pre-renal causes, there's some volume depletion involved. It might be dehydrated, there might be some hemorrhage. You might not be eating enough or drinking enough, or it might be vomiting and diarrhea, so much that's causing dehydration that's affecting the kidneys. It might be from an edematous stage, heart failure, cirrhosis, pancreatitis. They might be septic due to vascular collapse, and that's also not getting fluid to the kidneys, right? They might be over-diuresed. They might have a burn, causing skin loss or respiratory loss, or they're sweating. There might be some sort of third space, skeletal fracture or crush injury. Those are all possible causes, but essentially at the end of the day, assuming it's not a reversible cause and it's just hydration that's causing it, glomerulonephritis, interstitial nephritis, HUS, hemolytic urine syndrome, those are all causes of renal failure. The most common cause is sort of split between ischemia, acute tubular necrosis, or nephrotoxic agents, drugs, IV contrast. They down 4 grams of ibuprofen of fitness a day for the past 3 weeks because they're paying under control. And then acute tubular necrosis is also known as acute kidney injury. specifically, and that's more severe and prolonged, can come from severe and prolonged pre-renal. And post-renal is going to be stones, some sort of obstruction of the ureters, an outlet obstruction, possibly the prostate. Maybe there's a leak after trauma, right? Everyone feel okay with that? And here's just a table breaking up. And again, just a way of sort of breaking up what's causing it. You know, always check the BUN, creatinine, FeNA, urine osmolality. As long as it's less than 20, FeNA greater than 2%, you're probably dealing with intrarenal. Otherwise, you're dealing with pre-renal. So what do they look like? Well, if it's pre-renal, they seem thirsty, right? They seem more static. They have obviously fluid loss, maybe some weight loss, bad skin turgor, maybe collapsed neck veins, maybe even collapsible IVC. Inferior cable. Renal, they might have myalgias, fevers, bilateral back pain, hematuria. Post-renal have renal pain, kidney stones, abdominal distension pain, nausea, vomiting, urine. A good set of labs to try to determine whether you're doing pre-renal, renal, or post-renal. You want to try to get the urine output up as possible, but they probably are going to have a decreased urine output. You know, to BUN creatinine is elevated as the ratio. The potassium will be up, the calcium will be up, the sodium and phosphate will be down. You may have a metabolic acidosis on your hands, maybe some anemia. If you think that there's an upper tract obstruction, you can go with the renal ultrasound. If that's like ultrasound, will help to see if the IVC is collapsible. So when do you need to call in the big guns? When do you need to call in nephrology? Well, if you have a BUN over 100, creatinine over 10, that's pretty major. GFR less than 15, potassium over 6.5, or any other cardiac instability. If there's volume overload, so it's really, you can't just fix it with fluids, right? So volume overload. Or if there's uremia. And then if it's a dialysis patient with hyperkalemia or severe metabolic acidosis or pulmonary edema in there, consult nephrology dialysis early. Have you treated well again? Get the cardiac pre-renal, hydrate them, get the cardiac output if that's affected, being affected. Reduce intravascular volume if necessary with diuretics. Sounds funny, but if there's too much fluid down the line, it's not getting to the kidneys, some sort of congestion, then you might need to reduce it. Get nephrology, urology on board, and you know what's going on. You might have to be admitted. You get the signs of manage the symptoms as well as have. Yeah.
Sorry, I missed what you said about reducing the intravascular. Why do we reduce it?
So if what's causing the kidney failure is there's not enough fluid getting to the kidneys, right? Like let's say they have CHF and there's just a congestion backed up. And so it's not getting to the kidneys themselves, so you might just need to reduce the vascular volume. Well, sometimes. Usually not. That's not the number one cause of pre-renal, but it could be. If it's intrinsic failure, so how to make sure you fix the hypovolemia, get good volume going. Usually it's going to be from ischemia or nephrotoxic agents, so don't make it worse. Don't give them narcotics, don't give them sedatives, don't give them IV contrast when you're doing their workup. And you may need vasopressors involved if they find it shock. And then post-renal is really going to be about getting some drainage. Depending on where the obstruction is. If it's in the prostate, try to get a Foley in them. If it's in the ureter, you may need a percutaneous nephrostomy. And you can usually tell it's obstruction if they're acutely uric. You can get a bladder ultrasound to see if the bladder is full. Let's say you get the catheter and no urine comes out. Call a urologist, right? Now, if there is urinary retention for a while, chronic urinary retention. So once you get the catheter in, you may have something called post-obstructive diuresis. Now there's too much urine coming out, so you have to keep an eye on that. It might suddenly become hypovolemic or hypotensive. And if this is nuanced, at the end of the day, they're going to be admitted, whether it's ICU or the floor, but most likely the ICU. or they need to be transferred if there's no dialysis. Everyone good with renal failure? And let's say we're on the other end of the spectrum. These are patients who are not having acute renal failure, but they have end-stage renal disease. So what are some issues that can come? So they might have elevated troponins, and just as part of the ESRD, and that comes with an increased long-term risk of ischemic heart disease. Hypertension, CHF, all these are possible complications. You might need to reduce their preload. You might need to, by either inducing diarrhea with sorbitol or doing phlebotomy. Or if they're getting worse uremia, if they have really bad uremia from the ESRD, from the end-stage renal disease, you may start to see pericarditis. And this is not going to be your classic pericarditis, because what does normal pericarditis look like in English? Diffuse ST elevations. So if it's caused by uremia, you probably won't see that. You won't see that in the patient. So that's like a really good sort of hint. This is an end-stage renal disease patient. You got a really loud friction rub. EKG looks normal. So it's possibly uremia caused pericarditis and dialysis. There can be neurologic complications, maybe encephalopathy. And that's a diagnosis of exclusion. Don't assume it's related to uremia as well. The other causes of encephalopathy, such as infection or stroke. Might be peripheral neuropathy, maybe some autonomic dysfunction, like valve dysfunction, dizziness, and it could cause a stroke. There may be complications hematologically or GI, anemia. I have trouble with hemostasis, higher risk of GI disease, etc. That's the case, you may need to get DDA, deep precipitate. They may be immunologically compromised. They may have GI issues such as anorexia and nausea, vomiting, because they're going to be very uremic in stage patients. They may have chronic constipation. Hemodialysis complications. Well, sometimes after hemodialysis, most common cause is going to cause hypotension. Hypotension. Basically, it's a cardiac compensation from the end-stage renal disease. You may have myocardia, hypoxia, pericardial tamponade, all that stuff can lead to ischemia. And you're treated by giving them some salt, believe it or not. Infuse them with some oral saline, not help their things back up. Or they could have disequilibrium from the dialysis. And that could be from cerebral edema, nausea, vomiting, hypertension, seizures, coma, and death. So if that would happen, give them management. Give them management. Stop the dialysis. Yeah.
What's the most common cause of intradialytic hypotension?
So, good question. So that's a mistake on the slide. It's in the, I put it down in the comments. The most common cause is going to be underestimating the ideal blood volume.
Okay, that makes sense.
I apologize. Thank you. Those of you who don't have the comments on the slide, it's posted on the PowerPoint. It's posted on Blackboard. Thank you. So patients who are undergoing dialysis have a constant vascular access. So there might be stenosis or thrombosis in the area. So you notice that the Bruin through, which is normally there, is no longer there. So with that, you inject the thrombolytic, you do clot removal. There's signs of infection, signs of sepsis. May not be signs of pain or edema, swelling, or discharge, but there might be signs of sepsis. Might be from Staph aureus, our favorite skin organism, given vein agent. And another possibility from the vascular access might be a hemorrhage. Or hemorrhaging out, given pressure, put a gelatin sponge on there, plus some into pressure. You're trying to find what caused it. Extra heparin that they're taking, even protamine, which counteracts it. Or you can get a desmopressin if it's a new vascular access. And the last one, I know this is this chunky stuff, is often doing peritoneal dialysis. Endovascular peritoneal dialysis. They can get peritonitis. They get peritonitis. To find out what's causing it, see it, you'll see it might be cloudy. Send it off to the lab for cell count, and treat it with empiric antibiotics, and then make changes to dialysis. If you see infections around the catheter, again, you give them Cipro or first generation. That's the chunky renal stuff. Take a deep breath. We're going to the easier stuff, okay? Rhabdomyolysis. So who are you most likely to see rhabdomyolysis?
Those people that fell,
Was that?
the old people that fall and don't get
I
up.
think that is actually a really good point. Some people, they fall and they're down for a while between the dehydration and just the blunt foot trauma. Falling, yeah, they can go into rhabdo. What if it's someone younger? You might use it.
Drug overdose.
Marathon runners.
People like found dead on
Okay,
like through
yeah,
some sort of.
it could be, absolutely. Maybe something else.
Marathon runners.
CrossFitters.
CrossFitters, people who do a lot of like physical activity and hydrating them. And also remember, we talked about it with tetanus patients. After the months of tetanus, their muscles are good. It doesn't look like they're very active, but they are. But first, I want to share with you some numbers. And I'm wondering how many of you appreciate the importance of this number here, 274. Starting from May 30th, 2023, until now, until the day you get your short white coats, and you take your end of didactic year exam, it's 340 minutes. You are now at day 274. Which means if you're running a marathon, since we're talking about marathons, you would be hitting around mile 20.6. To put that in marathon terms,
Furthest I've ever.
assuming you're running the Baltimore Marathon, you're starting at Camden Yards, you would have run all the way over here at the harbor, and you'll be right around like here, rounding the corner, in and out the stretch. Few things can happen around mile 21, mile 22.
Oh, boy.
Those of you who have either run marathons, have seen people run marathons, or that is. And that is, they hit the wall. That can. You ever heard of hitting the wall? Stage where the body is completely given up all its glycogen, there's nothing left. And it is the hardest thing that you could ever do. But here's the really, yes, it's hard the last, you're gassed out, you're pushing through it. Okay. From a exercise science perspective, scientific perspective, let's say in your training before a marathon, you only get up to like 20 miles. On race day, will you be able to run 26.2? Absolutely. Absolutely. If your body can hit 20, you can hit 26 in your race conditions. That's the way the training works, the way exercise works. So, that having been said, congratulations, you made it to mile 20.6. Congratulations, that's amazing. You might feel yourself starting to hit a wall. Pretty normal, keep fueling, do what you gotta do, but you can do this if you made it this far. Okay?
Just put your face on there.
Yeah, I just felt that would be
It's
an
like he knew.
important message. As we go into wrap up.
It's like he knew. Right on the hook.
Looking causes, so we talked about a few, alcohol, drugs, abuse.
Right.
There'll be some medications, remember statins. We talked about statins a few times. And farm, diseases, environmental activities, trauma, electrical injuries can cause rhabdo, and infections. Infections. So what do they look like? Are they gonna have muscle? Because essentially the body is breaking down.
A job.
Stiffness, weakness, malaise, maybe low grade fever, and their urine is gonna be dark or brown. Remember we had that during the urinalysis? Is there necessarily blood in the urine? Not necessarily. What that likely is the myeloid. Severe nausea, vomiting, abdominal pain, maybe tachycardia. Half the time they don't even have muscles. And it can cause acute renal failure, maybe some metabolic derangement, maybe even DIC, compartment syndrome, other mechanical issues. Physical exam feel like it's totally normal, they just have really sore legs, maybe. And they're peeing brown, and it's weird. You need to get a good history, get that serum creatinine kinase, and you see some dark urine. The main lab when it comes to rhabdo is that CK. If that CK is high, it's probably rhabdo. This should be the word or. If the CK, assuming there's no heart or brain injury, is 5 times the normal CK, then it's probably rhabdo. Once skeletal muscle injury is more than 100 grams, more than 100 grams of the skeletal muscles have been injured, you'll start seeing myoglobin in the urine. The dipstick will show red blood cells. Maybe it'll even show hemoglobin, but you do the microscopic analysis, there's no. The levels will then become normal within 1 to 6 hours, so not having myoglobin urea is undiagnosed. Yeah, urinalysis, P, serum phosphate, uric acid level, creatinine, B, CC, PT, PTT, because remember they can go into DIC and much those circulations. Their potassium will be high. They have high LDH, creatinine. This is again the diagnostic urea, aminotransferase, hyperuricemia. What's interesting is, as all these phosphoric compounds from the muscles are getting into the blood, they're binding with calcium. There's going to be high phosphate, low calcium in the blood, because it's all getting deposited on those separated muscle cells. But high phosphate and low calcium, because the calcium is getting deposited on those muscle cells. After the muscles begin to necrose, so the calcium is released back into the plasma, and now you have high calcium north. And again, you want to rule out DIC, which is like complications of the CBC. Again, because kidneys involved with the number one thing, really IV fluids. IV fluids can be maybe bicarb. Some people talk about bicarb. There's not much evidence for it. If you do, just make sure you're making an isotonic solution. Make sure they don't put in metabolic acidosis, hypokalemia from the bicarb. That'll be bad. If they're having acute renal failure, they become in critical condition. On a heart monitor, measure their electrolytes. Want to make sure there's no renal disease, heart disease. Want to make sure they're not getting fluid overload. And keep measuring that urine pH, electrolyte CK, calcium, phosphorus, fever. Sometimes, right, because in renal failure, you may have hyperkalemia that can cause cardiotoxicity. This you would give calcium. It's usually worse the first 12 to 36 hours. If there's high phosphate, you might need to use PO phosphate binders if it's too high early on. And if the calcium is too high later, you can use sustaining diuresis. And when the phosphate gets under 1, you need to treat that. Insulin and glucose won't help you as much here for hypertension. Avoid NSAIDs and prostaglandin inhibitors, because it's going to be it's going to act as vasoconstrictive on the kidney. They know they're in pain, their muscles hurt, but don't fit the NSAIDs. Treat whatever's causing it. If otherwise it's some sort of exertional rhabdo, they're otherwise healthy, then you can just rehydrate them. Give them fluids for an hour or two. DO, IV, what have you. And then get another urine, measure their CK. If they're doing good, send them home. Otherwise, they have to be admitted for more IVs, diuresis possibly, managing any complications or treatment of the cause. If you're worried about dysrhythmia because of the electrolytes, get them into the bed. And consult nephrology for dialysis, especially if the potassium is just not. Questions on rhabdo? Stones. So if the stone is in the kidney, nephrolithiasis, it's not going to hurt. If it's in the ureters, it started coming down, it's going to hurt. going to be a sudden onset of severe pain, radiating down to the labia or possibly the scrotum, hitting where it is. Maybe the flank, costovertebral angle, the groin, and they come in waves because there's a peristaltic motion of the ureters. They're trying to get it out, so it's going to be coming sort of like colicky pain. And they're going to be restless. They're going to be walking around trying to make it better. There might be nausea. There might be vomiting. Might even have urinary symptoms from it. Maybe even some hematuria. Graphic representation. So first, we want to make sure there's no infection. We'll get a CBC, we'll get a BNP, CMP. Make sure there's no post-renal failure being caused by this. Getting your analysis, there might be an infection. Follow up on the culture to make sure you feed them for any antibiotics. Standard protocol of the kidney stone is to do a dry CT, no contrast. If they're pregnant or it's recurrent stone, get a renal or abdominal sonogram rather than a CT. And the ultrasound will tell you if there's an obstruction. So I just gave an ultrasound down being enough just to tell you if there's obstruction going on. You might see hydronephrosis, which is extra fluid around the kidneys. How do you know if they're pregnant? They tell you, right? No. All females of childbearing age are pregnant. So again, the difference between nephrolithiasis, ureterolithiasis, mucus of the kidneys are moving. This one here is ureterolithiasis, because of the ureters, but it's causing some backup in the kidneys. Syn kidney, also known as hydronephrosis. So how do you manage it? Well, in this case, we want to inhibit the esophagus. So NSAIDs are phenomenal for these patients. If they are throwing up, it might be fluids, maybe Zofran, maybe morphine or fentanyl, if you're feeling really nice, you're really in a lot of pain. Use alpha blockers like tamsulosin, terazosin, doxylosin. To help relax the bladder more. Antibiotics when infection is present on your analysis, either for quinolone or for infections. Most people go home and you give them red flag symptoms, come back, fever, vomiting, uncontrolled pain, gives them Flomax, some diuretics, strainers, they can find something comes out. Who's not going to go home? Well, if there's any signs of infection, maybe urosepsis, maybe that's single kidney, sign of kidney injury. If the stone is over 5 millimeters, they're not going to go home. Okay. Fever, you can make a call for it. Usually, well, 5 millimeters, they might be able to go home if there's no other signs of kidney injury, but they're going to need surgery probably. Okay. Pyelonephritis. So pyelonephritis basically is just extra special use. You're going to have those urinary symptoms, might have been going on for a while. They may even have gross hematuria. Usually, urinary hematuria is pretty common if it's just a UTI. It might be common if someone's exertional, we might see some microscopic hematuria. Sometimes it might be indicative of a stone. But if it's asymptomatic hematuria, often the vascular cause or neoplasm rather than infection. But again, before you use the C word in front of the patient, make sure you rule that out. Okay. Don't just answer it. Say, I think this is cancer. Hemorrhagic cystitis specifically is some damage to the bladder superficial blood vessels, could be from toxins, radiation, certain drugs and disease. Basically, it's the same thing as a UTI, but there's a lot of hair. So you want to make sure that it's not hemorrhaging to the point where it's but pyelonephritis itself is when the UTI progresses to the upper urinary tract. Might be organ threatening. Every time it occurs, it scars the kidney. It can lead to abscesses, sepsis, or even renal failure. This is why we test for CVA tenderness. If the UTI with CVA tenderness, you have to at least suspect you're entering pilot territory. Maybe there's fever, maybe there's basically the kidneys themselves become infected. So you may have those UTI symptoms. You're more likely to have systemic symptoms, fever, rigors, chills, malaise or weakness, nausea, vomiting. That's they may check their service criteria, make sure they're not having inflammatory response syndrome, tachycardic, hypotensive, tachypneic, febrile, all that would indicate they might be going to sepsis. Now, when we get an ultrasound, I'm gonna get labs, again, always check for pregnancy, get a culture and sensitivity on the urine. But really, it's gonna be based on the history and physical, and then the urinalysis will sort of help you. If they have urinary symptoms plus CV tenderness, as soon as pilot. Then just make sure they're not sick. So they can really be treated with fluids, pain, and nausea control, and if you feel they're stable to go home, give them some outpatient antibiotics. Now, often with UTIs, we prefer, I like macrobid. Macrobid's actually really good. It has less side effects unless I think it's resistant. It's not used with these things. Ciprofloxacin and most of fluoroquinolones have a lot of nasty side effects. But honestly, fluoroquinolones and Bactrim are really going to be the only things that are really going to treat highly. But the same thing you'd use to treat a UTI, just not. If they're going to come stay with people tonight, give them fluoroquinone, IV antibiotics, IV ceftriaxone, or even venous. Ultimately, though, final antibiotic treatment will be basic. Who gets to stay? Well, if there's obstruction, if they can't tolerate PO, their vitals are unstable, they have lactate over 2.2. Right? They're pregnant, other comorbidities. And what could compliance mean? Well, compliance could be something simple. So they can't afford antibiotics, so we're not going to go home, right? If you think that's the case, they're going to get admitted. We need to make sure they get that. Okay, so it could be a social act. If you don't think they're going to get antibiotics, they need a social act. Questions on PILO? Moving on down, urinary retention. So these patients are going to have a post-void residual of more than 250 milliliters. Ideally, you get them to urinate on their own. But if even after voiding the ED, you still see on ultrasound 50 to 150 cc of urine, so that's probably going to be retention. Usually, the people who present are going to get higher. You can use a bladder scan to see what's causing it, and then do a cap, do a Foley or straight cap to help drain it. If it's new urinary retention, they should probably get urology consult and then culture. So we want to find out what's causing it. Part of that's taking a look at the vital signs. If they have fever, you might consider an infection. The tachycardia and hypotension really might get better after you relieve obstruction. Palpate for descended bladder, see if there's any abnormalities of the meatus. Inspect the meatus or stricture, and you have to do a rectal exam to make sure it's no neurological issues or prostate issues. Sometimes in females, it might be the bladder. So it's interesting, where did the infection come from? So the infection may cause the urinary retention in some patients. And in some patients, it might have been caused by the urine. If you're absolutely certain there's no trauma involved, then you can go ahead and do an indwelling catheter. Unless it's post-anesthesia, they're just under so long that the bladder became too full, straight cap them, send them under. What if there's hematuria involved? There's hematuria involved, and you end up with blood clot, and that is causing obstruction. So you can actually use something called a 3-port Foley. After you cap them, you can actually irrigate the bladder and get rid of all that extra blood in the bladder. And once the fluid is no longer free of blood, then you don't need to keep irrigating, but they will need to be able to. If there's a stricture, if there's prostatitis, if there's any trauma to the urethra, or you're not able to get the cap in, call urology down. When I worked in the ED, there's a lady who had a backpack on, all these cap things, and she just went running down, pop the cap in, and went somewhere else. I think she was running to the hospital with her backpack. Get a urinalysis culture electrolytes beyond creatinine, renal failure, and measure the urine output. To treat it, if it's being caused by bladder spasms, you can use oxybutynin. Now, here's an interesting thing about oxybutynin. It will stop the spasms, but it's anticholinergic. Way back to the beginning of pharm, anticholinergic is going to do what to your urinary system?
He retained,
It's going to cause retention. Let's be careful. If there's spasms that are painful, do pain management. If you think it's BPH, you give an alpha blocker. If there's no UTI, there's no reason to do antibiotics. No UTI, there's no reason to do antibiotics. If it's chronic, then they might have that post-obstructive diuresis. We spoke about that. You might see, if you see more than 200 milliliters of output in more than 4 to 6 hours, then you might have to worry about incoming post-obstructive diuresis. Might need to put some fluids to make sure that. What's causing it? Isn't offending med, any infectious and neurological causes. You have to follow up in 3 to 7 days before you know it. So I actually had a patient walking in and working at pediatrics. I was working at pediatrics right down the street from the other urgent care, which are me. So it's really good. And most of the negative stories about urgent care, but the nameless ones. Anyway, so a 17-year-old kid came in who was on benzos. Because of with anti-anxiety and it causes urinary retention. It was like, I just need a calf. Sure. We didn't have any calf, like we all like baby calves, so we didn't have any calf that 17-year-old guy. So I go running down the street to the urgent care I used to work. I'm like, hey, yeah, I used to work here. For a calf kit. Why? I have a 17-year-old who needs a calf. Do you want them, or should I just like, no, you can take it. It was great. He took the kit, ran back, and yeah, it was fun. It's like ran back with it. All right. All that to say, sometimes it can be anxiety medications, anxiolytics. All right. Renal trauma, then we'll take another break. Okay, so usually renal trauma is going to be some sort of blunt trauma, usually hematuria, but maybe absent, but that may be absent. The amount of hematuria coming out does not indicate how severe the disease is. Kidney, often it can be handled non-operatively. You may need to do angioembolization or urinary drainage. You might need to do renal exploration, repair it, partial complete nephrectomy if it's really bad. And then you'll do a CT scan with contrast in this case, because you want to assess parenchymal versus vascular. So we still have about 60 slides left on male GU, but this stuff is going to be like much easier. So why don't we take a quick 7-minute break? Come back and do it, okay? Okay, because it is related to blood flow. Priapism is essentially a hydraulic situation. We can have normal, involuntary, persistent erection for more than 4 hours of venous or clitoris, which is very rare. You may hear in commercials for erectile dysfunction, if your erection is not in 4 hours, you see a doctor, correct. It may be unrelated to sexual stimulation. It's unrelieved by ejaculation. And like with any ischemic tissue, thymus tissue, it's actually one of the true urologic emergencies they're going to deal with. But there really are 2 types. There's high flow, referring to the amount of blood going to the tissue, and low flow. High flow is non-ischemic. Low flow is this. High flow is non-emergent. It will usually resolve on its own. More rare, and again, it's not painful. It's not rigid, ridged, and there's a good blood supply. It's often due to a ruptured artery from injury to the penis or perineum, which would need to be repaired. Essentially, what happens is with priapism is the corporal cavernosa become persistently engorged, and often that's because the disturbance in the mechanisms that normally affect the tumescence. But the glands remains flaccid in these cases. Ischemic pain is it's the most common type, and it might be some sort of mechanical interference or blockage of the draining venules, either sickle cell crisis or leukemia. It might be due to a prolonged relaxation of the cavernous smooth muscles. For example, someone with injectable intracavernous prostaglandin P1 helps erectile dysfunction. It might be due to infections, malaria, spider toxins, or it might be due to drugs, Viagra, trazodone, cocaine, alpha blocker, antidepressants. If someone is coming to you and saying, "Hey, I just want trazodone to try to help sleep on a flight," I have trouble sleeping on a flight, and trazodone. I would encourage them to try it out before they're in the plane first, make sure they don't have any unfortunate side effects, because transatlantic flight would be a pretty hard place to discover you could try the trazodone. At 4 to 6 hours, tissue damage begins. Okay, at 12 hours, it begins to be injury to the actual smooth muscle. And at 24 hours, there's irreversible damage. And it's a third of the time, and it results in impotence. Usually, you will consult urology, but sometimes you might need to start the process on yourself. You start with draining 5 milliliters of blood to decompress the corpora using a large bore needle. Usually, one drainage site is enough for both sides because it communicates bilaterally. Often you're going to need a little more than 5 milliliters, but you can, that at least will get things started. You'll get a cavernous blood gas to determine if it's high or low flow. Then you'll do a phenylephrine injection every 5 minutes or so, for about an hour. And the goal of that is to contract the cavernous smooth muscle and allow venous outflow. And they may need surgical drainage or prosthesis down the line. Damages. And just make them aware that no matter what you do, a poor outcome is still going to be medically legal. When you take a look at the blood gas, you'll notice with the ischemic priapism, the oxygen level is much less. There's less oxygen in the blood. That makes sense. And a higher degree of CO2 is actually going to be a little more acidotic. Questions on priapism? Phimosis, paraphimosis. So the only reason we're discussing phimosis is almost never an emergency, but it's to help us remember to differentiate from paraphimosis. Phimosis is where the foreskin has been reduced over the glands and it can't be pulled back. Physiologic phimosis may be possible until 3 years old. It's a pediatric note. Parents should not try to force retraction of the foreskin children under 3. They may need urology follow-up and treatment if it's really stuck, but it's not an emergency. Hydrocortisone can help. Try that with hemostats. Don't force a retraction, which will then not be able to be reduced. That will cause paraphimosis. Paraphimosis is going to often be caused by a well-meaning healthcare worker trying to fix a phimosis. This can almost have a tourniquet-like effect and can cause arterial compromise and gangrene. Call urology. However, while urology comes down, you can actually begin to treat this in the emergency room. This is something you can start to treat in the emergency room. Sorry, these texts came out so tiny when I converted it. I apologize. But computer. First, you just give circumferential compression for about several minutes, just to reduce the edema and swelling. Maybe put a little IV tourniquet around there and right. And then you'll come back with a small 22 to 25 gauge needle and make several puncture wounds. Now, before you start this, you might want to throw some EMLO on the area. Maybe some that might just help you move through this a little easier. Intranasal in the bathroom. Oh, that's your stuff.
Crying.
You just chill out there, put some in my hair, and I'll be back. Right? Okay. Make those small puncture wounds. That's going to help express the deep edematous fluid from the glands. And then, once you've gotten that swelling down, you'll actually, put pressure on the gland with your thumb and then use your fingers to pull the skin down over the glands. And sort of like a steady pressure, eventually you'll get it back under. If you're still not successful in that, well, you called urology about 15-20 minutes ago, they should be arriving from. And you'll say, hey, they need a dorsal slit. I did, yeah, thank you. And a dorsal slit essentially is, they will cut a slit in the skin, reduce it. You would use lidocaine before you do. Would you use epi?
No.
Ideally not. And you can do it, use an ultrasound, you just do a full penile nerve block. They're gonna probably need a circumcision. Fibrosis would have, but if it's causing this much issue, circumcision. Yeah. Sorry. Trauma or fracture. So I was having a dinner with the family, and they had a 13-year-old, 15-year-old boy there who was amused by the fact that I didn't know this. He was like, okay, what's like the grossest thing that could happen? What's the worst thing that could happen to someone's like genitals, penis? And I was like, look at the parents. Is it okay if I answer this? Like, yeah, like, probably penile fracture. But what? But what about the testicles? Probably deglutting.
Oh.
The kid like ran out.
Throat.
And it's on the truth, right? So, a penile fracture is a traumatic rupture of the tunica
Right on.
and the corpus cavernosum. This is again, urologic emergency, but it is one of the ones that you will not treat in the emergency room. Swelling and ecchymosis. You'll notice there's an S curve to the penis deviating away from the tear. And there may be some blood from the anus that may indicate a lethal injury, which is possibly 30% of the penile fractures. There's an acute tear, often caused by a sudden blunt trauma or bending of an erect penis, possibly from a female dominant sexual position. In a third of the cases, rough masturbation, rolling over in bed, hastily removing or applying clothing while dress, wrapped,
Roll. Good to meet you.
Right, frisbee.
from
Don't roll over.
from a developmental education perspective.
It's so hot here all of a
Parents,
sudden.
teenage boys, not an okay thing to talk to your teenage boys about, like, if you masturbate, you might get a penile fracture, that's not.
Must be, but rubbing
Um,
it real hard.
You'll get chlamydia and die. You will.
It's rare, right, but it's easily
Is that
diagnosed, right?
Gonorrhea or?
Now, check up, I have a been penis, can you help me? Swollen, this other tender, there's history of
They're gonna
sexual
go to the
abuse,
ER.
this is happening. Usually the reason it's not involved is your retrogram is highly, recommended because you don't have damage. They'll need surgery, they need surgery to put it back,
Has to be on.
and there's a science work how this. So again, you're on consult, pain meds, pre-op labs, we're doing surgery, and that's the weight curve.
Oh, yeah, I knew there was gonna be some sure.
Portion, this is the do not miss. Any kid, probably, really anyone, any male with any lower abdominal penis. Portion, okay. And do not miss this. And adolescents will lie about their lower belly pain, there's a secret pain, or it's just radiating to them, but you have to go out. The true surgical emergency, you have about 6 hours until the testicle becomes necrotic. Essentially what happens is the testicle rotates around the spermatic cord and that leads to ischemia. Sudden onset of pain, usually, however, half the time, there's this history of sort of intermittent symptoms. There are less emergent cases, there's an appendiceal torsion, right now, but they can occur at any point, awake, sleep, sexual activity, usually after vigorous activity or trauma. When you do the physical exam, tender, firm, swollen, Often the testicle is elevated in the transverse lateral testes. There's a lot of cremasteric reflex and a negative trend sign. You remember what those are. Cremasteric reflex,
Stretch the leg.
Stroke it.
right, stroke left side, lateral testes should contract upwards. Trend sign, elevated testicle. According to the book above the pelvis, not everyone's body habits allows for that, but elevating it should relieve pain. If it doesn't, it's negative. You're still in pain because they have a twisted testicle, lifting it doesn't do much. More epidemitis, lifting it up.
Yeah.
These are not, honestly, these are not reliable enough. In theory, they should be clinical, but the ramifications of missing a torsion are so dire that someone doesn't with testicular pain, they get a doctor. That's it. Right, that's it. Once it comes in, testicular pain, they get an ultrasound. Getting your analysis, make sure there's no tonsillitis or other infectious causes. Maybe it's a kidney stone. Maybe it causes testicular pain or just pain. Kidneys. It does radiate. And get a urology consult, get them ready for surgery with pre-op labs and NPO, get some pain control. Now, again, this is something you can start to treat in the emergency. Paraphimosis really don't know you might fix by the time the urologist gets there. Everything else, you will still probably need surgery. But this can at least save you some time, because time is tissue. Most of the time when there's a torsion, it's going to be in a lateral to medial direction. So that's the way it twisted. If you want to detorse it, the image they give is that of opening a book. So when you open a book, medial to lateral. So you twist the testicle back, medial to lateral, as if you're opening a book. That should hopefully untwist the testicle. And it's not just a fix it. Sometimes you might need to be 180 to 780 degrees.
Any of these things.
How do you know it works? Well, they feel better. Okay, now you have normal flow of ultrasound. They still kind of need surgery, but at least you cause less chance with complications. Very good time, they might need medial rotation. However, so the majority. This is the opening of the medial to left. Prostatitis. We talked about this last semester. We may have pain with defecation, scrotal pain, perineal pain, back pain, ejaculation. They may have a tender prostate, not just because you're doing digital rectal exam, but because it's actually tender. We talked about how if they're already looking septic, if you're worried about a hot prostate, probably shouldn't do a digital exam. You could push on the perineum if they refuse the area, but you're probably going to treat this based on symptoms. Again, if you're worried about a hot prostate, toxic prostate, sepsis. And again, it could come from a narrowed urethra. The swelling of the prostate could cause narrowing of the urethra. It may cause possibly a UTI or urinary symptoms. Give them antibiotics, give them fluids if you're worried about infection. The sitz bath can be helpful. Then they shouldn't sit too long to write vibes and other things. Now, you may remember that there are two ways of treating prostatitis, right? You have to decide, is there a concern for an STI or not a concern for an STI? They sometimes say it's based on age. For some reason, it tends to be people over 40, it's not from an STI. I don't know, that seems pretty ageist to me, but okay. But just get a good history. If you don't suspect an STI, then treat it as E. coli. Give them a FOX, 14 to 28 days. If you think it's an STI, treat it as an STI, ceftriaxone, and then 2 weeks of doxy. If there's a history of anal intercourse, give them fluoroquinolone, as well as Roceptin. That way you're treating everything. Okay. Yes.
So you're adding the fluoroquinolone to the doxy and
You
Roceptin.
don't need doxy, fluoroquinolone.
Okay.
Yes. But you do need the ceftriaxone. That way you're treating both E. coli as well as hospice.
Would it still have the chlamydia coverage though?
You know, I had the same question during the research. It could be the CIPRA will cover it. Yeah, I hear you. Yeah. Yeah, it's worth looking into. It's a good question. I had the same question when I was preparing this. epididymitis and orchitis. So there's a big difference. Epididymis is inflamed, epididymitis is inflamed epididymis, orchitis is inflamed testicle. They're just stuff in prostate states. So epididymis is the tube on the back of the testicle, basically it stores and carries sperm. And epididymitis is the most common cause of pain in an outpatient setting. There's infection, white blood cells infiltrate the area, causes congestion, causes edema. There's an increased risk of abscess and necrosis, which is why it can be emergent. And often it's going to be 1940. It might be a gradual onset, scrotal pain, swelling, urinary symptoms, abdominal or flank pain. There might be some urethral discharge. If you're hitting fevers, you're pretty late in the game. Same thing with nausea and vomiting. And you'll notice on exam that, you know what? I messed up. No, I take that back. We'll see the age thing comes in with epididymitis, not with prostatitis. Thought it was. So prostatitis or solar-based investigation, see in epididymitis is edematous tender epididymis, abscess, that's a bad sign. Transient sign is positive. It's better when you lift the testicle up, and it may be localized to the superior proximal testicle. So this is what I was saying before. You assume E. coli, if they're not sexually active, they're older, some sort of obstructive neuropathy, and then again, you'll treat for gonorrhea, sexually active. If they're pre-puberty, you don't have to assume they're sexually active as soon as college. You don't want to treat them for GC chlamydia, get a urinalysis, get a testicular ultrasound because hey, they have testicular thing. Remember, you need to make sure we're not looking at torsion. You want to make sure there's no abscess. And then this is what we were saying before. You want to give them, if it's anal intercourse, give them Roceptin and Levaquin. If they're older, just Levaquin or Bactrim, and then younger, do Roceptin plus dots. You're not getting that chlamydia coverage. I have to look into it. The fourth one. Struggle support, ice, NSAIDs, and pain. All right, so orchitis is an inflammation of one or both of the testes. Usually it's bacterial, usually it's a sequelae from epididymitis. It's pretty rare to have orchitis without epididymitis, and sometimes have epididymal orchitis, I think. But you treat epididymitis, it cures orchitis. Questions on the infections? Moving to the testicles. Back to testicles, yeah.
I'm just gonna say I looked it up in the.
Yeah,
It is Alzheimer's.
it has chlamydial coverage. Nice, that's what I was thinking, but I didn't have that coverage. Thank you. Fact checker. Okay, yes,
Yeah, but only, Cipro, it's not.
okay, is that what you saw? So that's why you didn't especially specify that plus. Yeah, thank you. Okay. Trauma. And I'm not talking about the trauma that comes with the now.
Yeah.
So blunt trauma, I mean, this is every move in the 80s or 90s that someone receiving testicular trauma is a joke. So good. It's been some sort of blunt trauma, sports injury, maybe an assault, might be penetrating trauma, stabbing, gunshot, industrial accident. And then degloving, that's what get trapped in machinery or a horse saddle. So there's bruising, extreme pain. And because it's an injury to the area, especially if it's blunt, the chance of a saddle injury, you want to get a urinalysis, make sure there's no urethral trauma. Get a retrograde urethrogram if there's blood in the meatus. Get pre-op labs because again, you're worried. And if you look in the letter of OLE, it goes into specifically when you will need MRI pre-op labs and possibly surgery versus being able to treat relatively the letter of OLE. Ideally get an MRI, it's not, ultrasound with Doppler or CT is fine, you get an MRI. It's relatively minor, again, just struggles toward NSAIDs, narcotics is really bad. Ice packs, bed rest, neuropathy. Complications involve hydrocele and metacele, infection, infarction, necrosis, torsion, abscess, infertility, or acne. Questions on?
Can you repeat what pre-op labs are?
So that's gonna be basically just CBC, CMP. And, usually that's just to get a good baseline before they go. Into surgery,
Okay, thank you.
maybe go like. So, Fournier's gangrene. So this is the necrotizing fasciitis. This is an emergency to the point where they must be in the OR within hours of this. Okay. Is a necrotizing fasciitis. Very rare here. It can spread up to 2 to 3 centimeters per hour. Per hour. Mortality is about 50%. So often might start with an infection of the rectum, urethra, or perineum. Maybe they have diabetes, appendicitis, that infection spread, IBD, diverticular disease. Maybe they have some sort of instrumentation or GU procedure, or scratch the skin that got infected. Maybe they have an indwelling cap. Maybe they're doing heroin injections in their groin. Any trauma, instrumentation, abscess, or fissure in the perineum, anal intercourse, drug injections, piercing, untreated epididymitis, infections from circumcision, burns, fairly less common. From women, it could be from a vulvar varicose abscess that didn't get treated, septic abortions, and sometimes, and often it's going to be polymicrobial, maybe 4 germs at a time. Strep, staph, Enterobacter, anaerobic fungi, all be at the party. Come in, fever, lethargic, may have intense pain and tenderness in the groin, dusky appearance of the groin, becomes gangrenous and becomes sepsis. So it's hard to figure out sometimes. You have to look at those vitals. Do they look like they're going into shock? They may have perineal, scrotal, or rectal or genital pain, but you look down there and it just doesn't seem that aggressive. Might look normal, might be erythematous. Sometimes, yeah, it's cyanotic, looks gangrenous, and yeah, you get money, you know exactly what's going on. Usually they're acutely ill and toxic, but not always. But the pain out of proportion to exams is going to be here. That's when we tell you there's some serious. Don't underestimate how severe it is just because they look okay, right? If it's crepidous, if it's crepitudinous, then you're in trouble. And it's really good. It can look gangrenous like this, or it could just look erythematous. You might think this is a burn, or even just look cellulitis. But in this area, you have to be worried that it gets possible gangrene. So what do you do? So, I mean, you want to get your CBCC coaxium because they're going into surgery. Make sure they're not septic. Get that lactate, get a blood culture, get a urinalysis, culture sensitivity of the urine. And here's where you find out, this is the number one diagnostic thing you need to do is that get a CT with IV contrast.
You're gonna call me.
Get
She can come
that
in at 11.
IV contrast of the abdomen and pelvis.
Honestly, that's fine,
And you'll
but
see,
I
you'll
perceive
see,
you'll
you'll
call me and tell me
see
what happened. Oh, I will.
see abscess formation. See subcutaneous emphysema, that's a hallmark. You get an ultrasound to rule out torsion or abscess or orchitis.
If I didn't
They're
have a
not gonna
feature when I
tolerate
got
it.
it, right?
They're not gonna tolerate sitting there with ultrasound gel on their testicle, with you putting yourself there, it's just too painful. At the end of the day, honestly, you're probably going to need to transfer them to the closest burn center to the OR before you. Usually the clinical diagnosis, if you're really worried about that, get the OR activated. But yeah, the CT with contrast can be what it allows you to get
I'm scared.
the surgery more easily. An emergent consult with urology and surgery, stabilize the patient, give them certain broad spectrum antibiotics, bank plus. Everyone good with that? Renal stretching. urethral trauma. Anytime there's pelvic trauma, anytime there's a saddle injury, no matter the age, you're jumping over like a rocking horse, whatever, and they trip and they come over the saddle, right? They're kids or however old they might be, suspect urethral trauma. So don't place a phobia in these patients until you check the means of blood and you've done a rectal exam to make sure the prostate's not too swollen. If there's blood in the meatus, if it's a high writing prostate, don't place a prostate. Don't place a phobia.
What is hungry?
If there is a high writing prostate or there's blood in the meatus, get urology report. If you don't know, get urology report. Yeah.
High riding prostate,
Is
you
that?
just can't palpate it.
I think that you would feel it more so because you're feeling the top of it, right?
Oh, okay, yeah. That makes sense.
Right, so it's not you feel much higher than it normally is.
Got it.
Normally you're feeling the top of the prostate.
Mm-hmm.
It's actually low.
So what do you do if there's urethral trauma? How do you put a phobia in? You might need to do a cystoscopy with a catheter over a wire to get it over the prostate, or maybe even a suprapubic cystoscopy. Okay. So this that happened with jackets in the chin, but we're going to talk more about what happens if somebody gets stuck in the zipper. So what do you do? Someone comes in and what's it? There's something. What's the movie or something?
The one with Ben Stiller in the blue suit.
Yeah, something that's stuck in the zipper, right? Yeah.
It's so horrific.
I think it is something out here.
So listen, in theory, you could probably even take care of that in an urgent care. They will need to go. They probably will need the urology follow-up. We could probably really take care of it. That's so what do you do? And again, on the Betterbilly, if you have the digital version, we have great videos of how to do this. Don't worry, there's not an actual penis involved. It's a flesh colored glove. So first, you just get everything really lubricated with mineral oil, the skin, the zipper, everything. Sometimes that's enough. Sometimes you're good after that. However, if that doesn't work, then you might need to move on to doing some anesthesia, maybe even systemic if necessary. Either do the dorsal penile block or anesthetize the skin. Again, no epi. Nonetheless, going to take 45 minutes. Don't have to tolerate that. First, you don't have to destroy the clothing. Just cut away the zipper. Right. Once you have just the zipper there, right, and depending on how it worked out, either they're still wearing their pants, they're not wearing their pants, you just have a zipper sitting there. Where is the skin trapped? You have to think about how a zipper is made, right? So you got the teeth of the zipper, the part that you zip up. So then you can just cut the teeth below and above the zipper. If it's, you may have to be able to cut along below the actuator, the thing that zips it up, and just pull everything. That's possible. If the penis is stuck in the actuator itself, then what you can do is you can just cut the median bar of the zipper of the actuator, and you can actually break the actuator apart by sort of clamping, taking two clamps, just twisting in two directions. It's gonna pop the zipper apart. You can practice in the zipper at home if you would. Or you can use a small flathead screwdriver just to sort of pry them apart. So that's nice because, okay, so that's a 15, 20 minutes, they can go home. Last resort, you can do surgery or circumcision, like if that's what the problem is, usually not necessary. And of course, do a tetanus vaccine, sure that they clean up, give them an appointment. That's a lot today. How's everyone? So next time we're doing environmental injuries.
It's like